So we don't typically do a ton of introduction because it's already been posted with that. Joe, we were just talking about a lot of things, but I think tendons is probably a good place to start here. And I know one of the things you and I have talked about is the difference between external load and strain on the tendon, and kind of how that it can be confused, conflated. You're one of the people who's hammered on about heavy loading for a long time. And then we recently worked on a piece together talking about how maybe the heavy slow load isn't actually doing that either. But kind of wanted to start off just with the idea of external versus internal load. Why do we like what does that mean to you? What is that you're thinking about?
Yeah, it's interesting because in the 20 years that I've been looking after tendons, probably a little bit longer now, actually, probably 30. Um, we only ever considered external load, and I don't think we actually knew what we were doing. And there was a lot of confusion around, is it the muscle that we're affecting? Is it the tendon we're affecting? Is it the brain we're affecting? What are we targeting here? And we just walked on as clinicians and really didn't go into thinking about what are we affecting. And now when I lecture, I talk about actually separating what we achieve in the tendon to what we achieve in the muscle, to what we achieve in the kinetic chain, to what we achieve in the brain. And we actually have to deal with all of those things because all of them, your external load sort of independently affects each of those structures in a different way, because each of them has to be resilient and have capacity in a different way. And so each of them needs quite specific external load to actually have an effect on the tissue structure, tissue mechanics, whatever you want to call it. And we have to be careful with the words that we use, and I'm particularly bad at doing that. So if I use an incorrect word, feel free to pull me up. But I think now we actually realize that each of those tissues needs a different stimulus, and our rehab program has to actually cover all of those tissues and all of the stimuli that we need to actually be effective.
Yeah. So one of the interesting things, I think Boehm's systematic review really kicked into high gear that idea of 70%. But then you look at some of the work with their group, and I'm blanking on the other group he's done a lot with, and I probably can't pronounce their name when I do it, but they've done a series of papers looking at what rate, what load, makes it the largest change in tendon adaptation, and they were finding internally the load, that strain being somewhere between 3.5%, 4%, or up to maybe 6.5% or so seems to be that sweet space where we're getting enough of the strain to create adaptation. And when they looked at the external loads, they're actually finding them around like 90% or more. So pretty heavy there. And how, like, I mean, you travel all around and lecture, and I know we've had these discussions privately, but how often do you find people actually anchoring load and then prescribing heavy enough? Like, is that one of the biggest things? I know we can also then go into the movements selected and whether or not you're actually loading the tissue you're trying to load, but you can wave your hands around, and if it's not heavy enough, it's not going to do anything anyway. Do you have any thoughts on that 70 threshold versus maybe even needing to be heavier? Or
look, let's go back to the fundamental premise of your question. If I go around and see what people are doing in terms of loading, it's the most incompetent mishmash of loading that you've ever had the displeasure of seeing. And I did do a tweet on this probably a couple of months ago, and it just garnered an amazing amount of responses, is that we chronically underload musculoskeletal tissues. And most of the time it's because we don't know, particularly physios, don't know strength and conditioning principles, don't know about tissue strain, don't know about internal versus external load. But for me, the big thing is that you have to experience load yourself to understand what loads you can place on your tissues. You know, what's the point of prescribing a leg extension for somebody unless you know what that feels like, where you feel it, how you feel fatigued at the end of 5 reps, and what weights do that. It's awful that people don't know the principles but never experience it. They're the two things for me. So what happens then is you default back to underloading. You default back to TheraBand. You default back to body weight loads. You go with stuff because you feel safe in that load. You don't feel that you're overloading the person. You're not overloading your brain. You know that you're within the limits of your understanding. And of course, what happens is that we then try and send people back from your rehabilitation, in inverted commas, to, you know, a sporting load or an activity load, and the jump's just way too big, and nobody's transitioned it correctly. You know, it's not only just getting the initial load right, but nobody's transitioned it correctly so that the tissue strain, you know, the external load is sufficient for that person to recover and get back to where they are. So there's so many things that frustrate me, and that's probably one of them. Yeah, so let's leave it there before I get onto all the other things that frustrate me.
Yeah, no, I mean, that if you look at, like, one that I know Rich Willie and I have talked about a few times is the soleus loading being done by doing a bridge and just coming up on your toes.
Yeah.
Right. And just basic biomechanics tell us that the amount of load, bilateral, half your body weight, to be generous, like, just because the muscle is active doesn't mean we're getting sufficient load. And one of the interesting things, though, you talked about never having experienced it, and this is an ongoing debate as well, is, do you need to have done the thing that you're trying to get the individual to do? I find a lot of times the argument misses the point of having experienced what a 5RM is for you is very different than saying that you need to be able to do a maximal back squat, or you need to be aware of what that would look like, right? You need to be aware of the fact that if somebody's doing a 5-rep max and there's no drop in velocity throughout the set, they're probably not hitting a 5-rep. Like, there's certain things that you should see, and if you've experienced that yourself. But do you have, especially for yourself, when you're working with these higher level individuals, that's often one of the things that people push back with is, well, I can't do what they would do, so there's no reason why I should have experienced this.
I think you've just set the world record for the number of questions in one question. So absolutely, you know, I'm an old woman and I can't even get close to what these people need to do. But what I think I do know is what it feels like to be at the end of my capacity, the end of my ability to feel that maximum tissue load, and to know what happens if I try and do another set or another rep or something like that. So I don't think you have to be able to reproduce what you want people to do. Otherwise, no one would be able to rehab elite athletes, because unless you're an elite athlete yourself. But I do think you need to know, and I think you're right, recognize when the load is insufficient, when you can see that they're getting to what you've prescribed and it's just, you know, they're still talking about their chicken dinner last night, and you know that you're not even close to what that person needs to do. So I think that's, you know, I think that's enough. For me, that's sufficient. You can identify fatigue. You can identify whether your reps and your sets and all of that sort of stuff is hitting the mark. And then you're filtering that through, what does that person need to go back to your sport, to their sport. So at no point in the whole process are you not thinking about the end point. You know, are you going to give soleus exercise? I go back to the first part of your question. Soleus works at about 90% MVC in change of direction activities, because it decelerates the tibia on a fixed foot. Well, you know, if somebody is a change of direction athlete, you need massive soleus strength. And so you have to recognize that. And so you have to institute the right soleus type of exercise. And you're right that nobody does a particularly good job of any of them. But you then have to try and get up to those loads. And then you have to work out whether it's a pure strength you want, or is it strength endurance you want? And for some athletes, it's going to be strength endurance. And for some athletes, it's going to be pure strength. And, you know, all of those things come back into your plan. For me, from day one, you know, you never would be thinking about, you know, nothing on day one and just thinking about doing your exercises. You know, remembering that we all see Achilles tendon problems in ladies who just walk their dog a couple of kilometers. Well, if I don't consider her endpoint when I start prescribing my exercise, then I'm going to mess it up. But the same is particularly true of elite athletes. And that's the critical thing for me, is they're the harder ones. You can always underload, but you can, you know, getting the load up for those athletes is pretty hard. I don't know if I even hit all of your questions.
It was more of a stream of consciousness than it was a specific question there, Joe. So no, that was really the main thing. Is I think I had one of the surgeons I work with closely said something once a number of years back, and it's always kind of stuck with me. It was the first day I was hanging out with him, and we were about to go in to see a patient, and he said, you know, the biggest thing that I have a problem with physios is you've all made somebody too sore. And he's like, and that's fine. I like it. He's like, my problem is that you then take that. And what I find is most physios are not pushing my patients hard enough. And I find that I have to end up referring to a trainer if I want to see actual strength adaptations, because he said, and I get it, you know, nobody wants their patient coming back and say, I've been sore. This really hurt. This was a problem. He's like, but sometimes, you know, that kind of happens. And so he's like, that's his sort of biggest thing. So in that sense of, you know, underloading, where would you sit on, like, do you have any particularly practical approaches that you take? So the other was just a discussion. This is the question, right? Yeah. When it comes to anchoring your load, what approaches do you use to ensure that you're actually getting the load you need?
Okay. Oh gosh, that's a hard question. Privileged in that where we see our, what we call our desperate and dateless tendon patients, is that there's a gym involved, and we have plenty of time. We make sure we have plenty of time, because often these people have had, you know, 2, 3, 4 years of pain. We will take them down and we will make sure they can hit the targets that we require. Now, that's a privilege for me, and you guys don't always have that. But I think the big missing point in all of this is how you talk to your patient and what education you offer. And you, day one, say, listen, if you can't get to the gym, I'm going to give you a series of things to do. First of all, I want you to start one thing at a time and make sure you're not worse the next day, and then add one thing and make sure you're not worse the next day. So don't give them a 5 exercise program and get them to rush off to the gym, you know, every day for the next week. Of course, you're going to make them sore.
Right.
And talk to them about how, if it does stir you up, we've started you low enough that if it does stir you up, it's not going to be a massive problem. Actually start and talking language that this is not an issue. We are trying to hit the top of that peak. And I always talk about, we have to be loading you at the peak all the time. If we're down here, we're overloading you, underloading you. And if you're down here, we're overloading you. And finding that peak is hard. And it's different for every person. You know, we've all had the person in who you ask how their pain is. And I'll tell you that depending on which toothpaste they use in the morning, how their pain is different. Now, with those people, you actually have to be so much more sensitive to their sensitivity to their pain. And the longer they've had it, often the more sensitive they are, the more people they've seen, the more interventions they've had, the more failures they've had, you know. And this is a classic for us. We see people with long-term pain, you know, they've paid for stem cells, they've paid for PRP, they've seen all the best people, you know, one guy had gone to the US to have stem cells and all that sort of stuff. and they come into you and you say, well, you need a bit of calf strength, you need a bit of quad strength, and you know, you'll do really well. And they sit back and they can't actually process that, you know, in any way. Why didn't anybody tell me this, you know, ages ago? Why have I spent $30,000 trying to get this better? So they come in with this whole raft of things, and you've got to be talking their language right from day one, and about, you know, how it's not going to be in a linear recovery, that we, you know, and if we stir you up and we make you sore, brilliant. You know, we know where your limit is, and now we can do it. So if you can't go to the gym, always start a little bit under, start single thing at a time. Go with the safest things first. So if someone's got a patella tendon, go with a ton of calf stuff, because you're not going to upset their calf, except for delayed muscle soreness. Right. Well, you know, people know what that is. And then, you know, try and hit your isometrics at the right level. And I can talk through how we do that clinically if you like. But, you know, work above and below, and then just ease through so that they start to get familiar with what you're asking them to do. So I think there's a lot of time involved. If you want someone to come in and you just give them a sheet of exercise and send them out the door, that's not going to work. And certainly not for people with long-term tendon pain. You actually have to work through all of the baggage that they bring with them, about what it is and what's going to make it better. And you know, it's exhausting. You know, I see 3 patients in an afternoon, and I need a solid drink at the end of the day.
I really appreciate the point of this takes a while. Good. When we're loading for adaptation, all of the rules of strength and conditioning, as you mentioned earlier, come into play. And part of that is that this takes time. I think that's my biggest thing when I have people, is one of the first things is this minimum of months of building up to the point where you're capable of training, right? We have to train to the point where you're then capable to start training. Because if you're so sensitive, like we were talking about earlier, we're not training your tendon because we don't have enough load to change the tendon, right? So the 5 weeks that it took us to get to 80% was not tendon specific training. It was background work to get you to the point where you could then tolerate working on the tendon.
Yep.
You mentioned the isometric. I'd be definitely interested. I find blood pressure cuff for especially a lot of upper extremity stuff, where they can do a maximum pressure test and then they have to hold it at 80, 90 or whatever percent. But lower extremity with certain exercises, and depending on how strong the person is, the cuff tends to sort of max out. I'm also lucky in that I have, you know, force plates and isokinetic and plenty of load cells to where I'm testing everything. But I think everybody would, you mentioned you could discuss a little bit about how you look at that.
Sure.
Isometric.
Sure. So just to go back to your first bit about adaptation, how long it's going to take, and this is part of your process of dealing with your patient, stand them in front of a mirror and say, what do you see? And, you know, people with a tendinopathy are going to have wasting, usually calf, gastroc particularly, but quad. And, you know, can you see there's a difference here? Hop on one leg, hop on the other leg. What do you think about that function? You know, you want to go and run, and, you know, one leg's acting like, you know, something from a duck, and the other one's acting like a real limb. You know, if you go running on this, you're going to run around in circles because one leg is working, one's not. And keep going back to that each time. So we often video people on the first time about how they hop and how they function depending on the tendon, and then we'll show them that the second time, and we'll video it the second time and say, you've improved amazingly, but can you still see there's a deficit? So you have to keep giving people reasonable targets and reasonable knowledge. Because if you say to someone, well, you can't, this is what I see all the time, oh, you can't run for 6 months, you've got an Achilles tendon, you can't run for 6 months. Well, why would I even believe you? You can't run for 6 months because you can't lift your body weight 5 times on a single leg. You have muscle wasting, you have no medial head of gastroc, you know, you have no, you know, capacity in your tendon. You know, give them a list of reasons and then give them a target. You need to be able to lift your body weight. You know, the ballet is 32 times single leg, full height, proper technique, all of that sort of stuff. That's what they demand. So this is what we're setting you. You need to be able to do this on the, standing calf raise. You need to be able to do this on the seated calf raise. You need to be able to run, 30 flights of stairs, or not quite, but, for an elite athlete maybe, and not be any worse the next day. So give them targets, and then they will buy into the process of getting to the 4 or 6 months that you've given them in the first place. Because if you just say that, they'll go and find someone else. So that's how we deal with the time issue. And we're lucky in the D&D clinic because people have tried everything before they get to us. They've been told everything that's rubbish in the first place. So by the time they get to us, we said, push a peanut to China with your nose. They do it because they haven't got an alternative. And someone sold you as the best alternative, but even so, you have to actually deal with the issues. So how do we prescribe isometrics? Just leaving aside all of the debate and all of the issues around isometrics, I find them exceptionally helpful for tendons. The issue in terms of not being helpful are 2 reasons. One, most people couldn't diagnose a tendinopathy if they fell over it, and they're often prescribing isometrics for non-tendon related pain. And the second thing is they don't load them enough. So Ebbs's stuff, as it was 70% MVIC. She spent 18 months piloting that. So we found that light loads didn't work and short loads didn't work, and it had to be that combination of heavy and long. And so everyone's gone off and done light and low and wondered why it hasn't, come back gleefully and said it doesn't work. And the answer is it's usually underload. It has to be isolated too. You can't do an isometric load for the patellar tendon in a squat situation because you've got, joints above and below and, 2 legs and all sorts of things. All right, so this is how we do it. What we want is the person to be able to sustain a 45-second contraction with good control. So where there's no perturbation, when they start to get really fatigued and you get some muscle fasciculation and perturbation, then the load is too heavy. If they get to the 45 seconds and chicken dinner's on what they're talking about, then it's too low, it's too easy. You want them to hit the 45 seconds with good control, but only just. And that's a really good, for us, seems to be a very good clinical way of determining a starting isometric load. And because you have your 2 minutes rest between, you're going to get muscle recovery, you're going to get cortical recovery, so that the load is not going to get heavier as you go through. It's not going to get harder as you go through. They should be able to do the 5 repetitions pretty much with exactly the same sort of, what's the word I want, integrity as they did the first one. So, you've got to, again, this is a time issue, and I understand that this is, again, something that perhaps you don't have, and maybe you do it on your second consultation rather than your first. You've actually got to do a isometric contraction with these people. You've got to run through the 5:45 seconds because you want to know 2 things. You want to know, A, does it work? B, you've got to get the right amount of load on it. And C, it helps you differentially diagnose things. So if you get to a decent load, 5 times 45 seconds, the person's no better on some sort of loading test at the end of the isometrics, go back and rethink your diagnosis. That's how clear I feel that isometrics change things. Now, they don't always take the pain away completely, but we look for a halving of pain. So if they've got 6 out of 10 hop pain, they do a really good isometric protocol, and it's 3 or less, then we say, yes, there is some tendon involvement. And then if it's still 3 out of 10 pain and it's an Achilles, for example, we'll then go hunting for something else that might be contributing. So we might do some neural sort of targeted stuff and then hop them again, and it goes down to 1 out of 10. So that there's a tendon component, there's a bit of neural component. If they get worse, then you're looking for something different. You put somebody with patellofemoral pain on a leg extension at 60 degrees with a heavy load, they don't like the first one. They can't sustain it, and they hate the second one. Whereas a tendon person will really be quite confronted by the first one because you're asking them to load heavy, and they think it's, oh my God, I've got a sore tendon. I've been told not to load all of that stuff. that the second one feels better, and the third one's pain free, and then the fourth and fifth are really, really quite good. So you get an improvement over the isometrics. If it's getting worse, then go back and think about what you're doing. Sorry, Scott, I'm talking a lot.
You're
Can
good.
Can I just talk to you about, I did a Zoom conference about an athlete in the US. We're talking a pretty good athlete here, you know, top level, whatever sport, with long-term patellar tendinopathy. And I was instantly suspicious because of the sport he played and the position he played and the length of time he'd had his symptoms. Didn't sound like a tendon to me. So his diagnosis of patellar tendinopathy, his knee was clicking, it was cracking, it was swollen, and he described his pain behind the kneecap. And the diagnosis in this elite athlete was patellar tendinopathy. Well, you know, throw your hands up in horror and walk away, because he can't play at the moment. They've now got 8 weeks to get him ready. He's had PRP and corticosteroids in his tendon. Of course he doesn't have tendon pain. I mean, just, yeah, it's exhausting. You can tell I get exhausted.
I mean, I don't see it as much as you, but I see the same thing plenty of times. And I think a couple things as you're talking that really, one of the key things is that idea of when you're having them, regardless of whether you're doing 45 seconds or 3 seconds, if you want them to be able to repeat the performance, you have to have an external method that is telling them whether or not they're performing well. And I think what I see a lot, and I don't know if you see it over there as well, is using rating of perceived exertion. Well, of course it's going to go up. You're getting tired as you're going along, right? What RPE is looking at our perception of how hard it is. And so to your point, I always do whatever I'm doing with them there with something objective externally that they have to watch. So whether it's a weight that they've lifted and held, or a dynamometer that we're pushing into, or the blood pressure cuff or something like that, then they go home. The next visit we do it again, because I know they're not going to, at home, they're never going to be working as hard as what I do. And that really, for me, is one of the biggest things. Is everybody thinks, kind of like you said, they wouldn't see it if they tripped over it, but everybody, there's a lot more people. The saying is, you know, it's kind of like sex in high school. There's a lot more people talking about heavy loading than actually doing it. And it's sort of the same idea here, is everybody likes to talk. It's now popular to say, yeah, load it. But unless you're objectively looking at it, then you can't say that you're, you know, getting that heavy load. But the thing to me, because I do want to touch on that a little bit with the isometric, is treating pain versus treating the tendon. Because when you look at a lot of the research done on tendon-specific adaptation, it's done isometrically. And the reason that at least to my understanding, is because it's so much easier to control. I use isometrics a ton because I have complete control over the rate, the duration, the positioning. I can tell this patient, and my dosage becomes very, very specific with isometrics. Whereas when I add coordination demands in there, I start being a little less certain. So I'm curious your thoughts. Isometrics, I know pain has become such a big thing, but ultimately what we're trying to do is create some adaptation, right? As opposed to just there. So I'm curious your thoughts, sort of broadening into that.
That's another world record of questions.
Just the last one, the idea of pain versus function when it comes to isometric prescription.
Okay, all right. So isometrics, from my perspective, and you know, based on our research and the research of others, have only really been there for a pain, to suppress pain, to change pain, to make people more functional. So you can't really separate pain and function, because if you have less pain, you function better. So that you, yeah, they're interrelated. But the surprising thing from Ebbs's study was this change in cortical inhibition that we saw. So this complete relief of cortical inhibition, which was a whole nother ballpark for us in terms of isometrics. And so, you know, in an elite athlete, you should be doing isometrics prior to a strength program, whatever that might look like, because you will relieve that cortical inhibition. You know, if you remember Ebbs's stuff, they were 19% stronger at the end of an isometric protocol than they were at the start. So why wouldn't we be harnessing that relief of cortical inhibition to access our strength stuff? So I think that, you know, it's very hard to separate them out. Often we do, just because in non-elite people, you know, it's easier sometimes to move on than just continue to do their isometrics. I guess for me, the other thing, you know, that they obviously do is, this is the way we make our tendon mechanically stiffer. So that's what we know. We condition the tendon through isometrics and heavy slow resistance. So we are having an effect on the tendon mechanics at the same time. So we're affecting the brain, we're affecting the tendon mechanics with isometrics, and they're both critically important. One of the reasons I tend to want to move on to heavy slow resistance is, just depends on, and I'd be interested in your thoughts, Scott, about, you know, strength through range. And, you know, I was always taught that if you exercise at one point, you get about 20 degrees either side. I don't know if that's still considered reasonable, but sometimes you have to be looking for different ranges and for strength in different ranges. And you could do isometrics at a different range, but you could also just do heavy slow resistance. The other thing for me, I think is important from a tendon perspective, is you need absolutely amazing eccentric muscle control, because that's the load, that's the muscle contraction prior to the spring being loaded in the tendon. So what happens in change of direction, jumping, whatever, is you get a rapid eccentric contraction of the muscle, and then you get then it holds isometrically, and then the tendon spring comes off of that, and then your muscle comes back to a concentric contraction. So that eccentric part of muscle contraction is pretty important to me. But, you know, in heavy slow resistance, we don't do it fast, but we at least condition the muscle to an eccentric type of contraction. Whether the concentric stuff adds stuff, it probably does. I don't know that there's as much evidence that that's a critical part. But from this, I absolutely don't want anybody rushing back to eccentric only exercises, because, you know, that lets us down as well for a whole range of reasons. So I'm not even sure I answered your question, but, you know, if you want to...
Again, it's less of a question and more, I'm just throwing ideas out there. I think that's interesting. The isometrics do seem to be position specific is what we see. However, the data does seem to indicate that the longer muscle length isometrics transfer better through range, which is also interesting when we look at, I'm blanking on his name. We were in the email thread where his was looking at the 10.
McMahon, Jared McMahon.
Yes. So his paper looking at actual adaptations in a length and muscle length isometrics as well. They're showing in series. I think the key to me with the isometric versus eccentric is a discussion of what is it that you're targeting. So earlier you said we have to be specific in what we're doing. If we're looking to create eccentric muscular adaptation, we need to train that specifically. And eccentrics, typically slowing down a repetition does not increase the force that the muscle's dealing with. It's not representative of change of direction type tests. And so most of the eccentric literature starts pointing to heavier loads, supramaximal type eccentric work, doing those sort of activities. With the isometric, you can train the muscle, you can train the tendon, and that's where I was kind of more interested in from a performance. When you look at the literature that shows tendon stiff, mechanical and sometimes morphological changes, almost all of the researchers who are just purely looking at how does this adapt are using isometrics because it gives them control over what the tendon does. They know exactly what's happening there. Um, I think we're gonna split into rooms here. Let people. I know that was a lot, and then we'll sort of reconvene. But it gives everybody a chance to discuss that briefly. All right. So as you're coming back, just double check to make sure you're muted. Um, if you're going to ask a question, do that. We did have a couple questions that were asked throughout, so we'll start kind of with those. Shelby says, I'm glad I'm not alone when I feel like Scott asks 100 things. Awesome. I'm glad. I'm glad too.
To you. I'm just like, I don't know where to start.
It says, imagine living in the head all the time. It's even worse.
I don't imagine.
Yeah.
Just kidding.
So, how specific do we need to be with our exercise choice in Achilles or patellar tendinopathy? I think you touched on this a little bit, Joe, when you were talking about the degrees of freedom, but I'll drop the stress shielding term, since I know you love that one so much, and ask you how stress shielding fits in here.
Oh God. I was an author on the first paper that talked about stress shielding, and it's a bane of my life, really. But you know what I think we miss is we don't, and people in strength and conditioning will realize how we've gone away from, isolated exercises right through to functional repetitions. And we can't, Jenny McConnell started this with the knee, that it has to be in the kinetic chain and all of that. And I think for tendons, that just doesn't work. You actually have to go back and isolate out each muscle specifically and load the bejesus out. But no, that's probably a bad thing to say in the US.
You're good. You're good. You're good.
Load the heck out of it.
There you
go. Because it just gets shielded. And can I give you a clinical story? I saw a guy with patellar tendinopathy in Australian football, elite Australian football. So the big boy, good athlete, had patellar tendinopathy. And I went over, he was in Adelaide. So I went over and we set him up for a program. And, and I went back 3 months later and I said, how are you going? And he said, oh, I'm playing, but my tendon's not much better. And I said, okay, well, how's your strength going? Because that's usually the thing you've got to go back to. They're usually not done enough strength work. And he said, oh, look, I'm awesome. I'm winning the squat competition in the club. So that, there's a competition for how much you can squat. And he was a big boy, so he could squat. I don't know what it was. I said, oh, that's interesting. I said, what are you doing on the leg extension? He said, oh, I'm not doing that because I'm winning the squat competition. So we sat him on the leg extension machine and he couldn't lift 18 kilos.
Oh, wow.
So that comes back to that, you'll hide, tendons hide. So one of the things that we always talk about is tendon pain is quite specific. If you load it, it hurts. And so what happens is the brain very quickly gets used to saying, don't load it. Patellofemoral pain and back pain and knee pain is a bit different. It can hurt a bit when you load, but sometimes it doesn't. It hurts when you sit or you lie. So your brain's not as clear about unloading, but tendons, the brain is so clear about loading. You do that, it's going to hurt. Don't do that. And so tendon pain really creates dysfunction and unloading better than any other pain, that musculoskeletal pain that I know. And so if you put it in a kinetic chain, and particularly on two legs, it'll just not load. And so you've got to go back and you've got to pick it out and you've got to load it specifically at each joint. So standing calf raise, seated calf raise, leg extension, leg press if you're lucky, 4-point hip machine for, your glutes and all of those other things. So, and then once you have a strength, then we tend to try and do our strength endurance more as a kinetic chain exercise. So put it back into the kinetic chain. So you take it out, get it strong, put it back in, and then your progression is to your faster stuff and your energy storage and release. So I think you have to be really, really specific early on, and that you can't budget. You can't go, well, you can sometimes go with body weight loads, depends on the person, but you have to, for me, it has to be really specific. I don't, get it. I don't know if I answered the question.
No, you did. Yeah, you got it. if you give the body an option, alternatively, it's going to take that one, because why would it load? Like you have to keep it honest, right? And you kind of touched on the other question that the next person had asked, which was key differential diagnosis indicators of true tendon pain. And
Yep.
if you want to expand on that a bit,
Sure.
The other one that's sort of coupled with that is talking about, it's not just type of contraction is what everybody talks about, but the rate of loading being something to bear in mind. So I think that those two pair up pretty well.
All right. Okay. So going back to the elite athlete I talked about previously, diagnosed on abnormality on imaging and pain on palpation. Now, neither of those are specific to a diagnosis. We know that 40% of the NBA players have patellar tendon pathology. They're not all symptomatic. So your imaging change that you can see doesn't tell you that the tendon is the source of the pain. And it's a complete misrepresentation to assume that it does. Secondly, palpation soreness. We showed in a study in 2000, so 20 years ago now, that pain on palpation didn't mirror imaging change, and it didn't mirror pain on the decline squat. And we know from other studies that if you poke a tendon, it can be the sorest, if you poke the patellar tendon, for example, sorest point for patellofemoral pain and sorest point for OA. So if you poke it, you still haven't actually differentiated where your pain is coming from. So you have to go back to fundamentals about listening to their history, what hurts it. If it hurts when they cycle, it's not going to be tendon because it's not enough load. If it hurts when they run, it's probably not going to be tendon because it's not enough load. But if it hurts when they change direction and jump, it's probably going to be tendon. But the two things that we say you must have for tendon pain, you must have localized pain. So tendon pain doesn't distribute. If they start to use a hand to say, you know, my pain is here, then you immediately start to think about something else. So localized pain, single finger, occasionally two fingers if you're lucky. In an Achilles, they'll often pinch it, but one finger. The pain will stay localized regardless of what load you do. So some people will come in, patellar tendon's the easiest to talk about, they'll point to it, they've Googled it, Dr. Google's told them that's where their pain should be. And then you say to them in your second question of your history, you know, first question, where's your pain? There it is. Okay. Does it ever shift? Oh, yes, it often runs around here or up here and does that when I do these loads. Tendon pain doesn't change. It stays in that one spot. And the third thing that's important is that it must go up as you increase the load on the tendon. So you must have a 1 out of 10 pain or 0 out of 10 pain with low load. And as you incrementally increase the load on the tendon, the pain must increase. So, you know, take a peritendon diagnosis in the Achilles. The pain will not be localized. It will be very, almost the inverse. It doesn't change that much as you increase the load on the tendon. But if you take patellofemoral pain, that won't change either. That won't go up in a linear fashion with the increase in pain as it would in a patellar tendon. So many things that give you good clues that it's tendon pain or not. You've just got to listen to them. You know, people just ignore them and they go back to abnormality on imaging and palpation soreness. Doesn't help you. You'll be wrong 50% of the time, probably more. And you know what? We rarely see patellar tendinopathy. Rarely see it. All the anterior knees that come to us are nearly all patellofemoral and being misdiagnosed based on those two criteria. So differential diagnosis is you have to be good. You have to be thoughtful. You have to be a good clinician to pick it out. Anyway, so that's it. Rate of loading. What was the question around that, Scott? How do we increase the rate of loading?
No, it was more about just teasing out that type of, it's not just about type of contraction, it's about rate, which I think pairs with what you were just talking about
Okay. Yeah.
more load, more pain. And so if I can make the question more precise, which is a change for me, you said as load goes up, pain goes up.
Yep.
We also know that tendons can do very heavy load if it's done slow. So
Yep.
my question for you is, are you saying, is it purely, when you're saying load goes up, more pain, is that load in the sense of the activity they're engaging in, or the load that you're putting on them in
No.
the clinic?
No. Slow and heavy for tendons is they love it. You could start them on 10 kilos and add another 10 kilos and add another 10 kilos, another 10 kilos. The tendon's just not going to complain at all because it's not high tendon load. It comes back to what is high tendon load. High tendon load is using your tendon as a spring. So it's energy storage and release loads, particularly. Talk about compression later if we've got time. But the thing about tendons is that they're viscoelastic, and the only way you can use a tendon spring is to load it very quickly. Because if you pull a tendon slowly and then hold it, it just gets longer because it's viscoelastic. The only way you can store energy in a tendon is to give it a quick tug, and then it'll return your energy. Okay, it can store energy if it's loaded quickly. So faster activities are what load a tendon, and faster activities where you use your tendon as a spring are the high tendon loads. So slow stuff does not hurt a tendon. So to give you an example, in the Achilles, to increasing load, we start them with slow double leg lifts. How's your pain out of 10? Where's your pain? Single leg. How's your pain? Where's your pain out of 10? Okay, these are both low loads. And if they've got high pain there, you're immediately thinking, whoa, what's going on? This could be peritendon, this could be neural, this could be posterior joint. You know, for example, if they go right up on their toes and they've got pain right at the top, then you have to start thinking about posterior joint as your critical thing. Okay, but that's low tendon load up to that. Then we'll put them on 2 legs and get them to jump. Okay, but we keep their heels off the ground, and that starts to store a little bit of energy in the tendon. Their pain needs to go up. Then single leg, pain should go up again, and then big hops, pain should go up again. So each of those sort of faster activities gradually increases the load on the tendon. So they should go in a perfect world 1, 3, 5, 7, 9.
Yeah, that makes so much more sense. As I think, at least for myself, a lot of times load gets conflated with external weight lifted, and your load here is, yes, force, but time that it's loaded in. So when you're saying tendon load, it is defined by the rate. Like, you can't talk about load without having rate in the conversation. That actually makes a lot more sense with some of the other statements made. Okay. That's very, very helpful. And I don't know if it's a US thing, but yeah, a lot of times when people say, oh, you got to put load on it, it's just force, no discussion of rate. But
no, the rate of loading is key. So Craig Purdom has these fabulous diagrams, graphs, that if you go from a single leg press to landing from a jump to a stop jump task. So stop jump task is the biggest load for a patellar tendon. The body weight loads on the tendon don't change. So there's in fact no increase in body weight loads. It's the rate of loading that changes. And it's the rate of loading that loads the tendon, because that's where you're storing energy in the tendon. That's what you need to return these people back to their trainings. That's why cyclists don't get patellar tendinopathy, a whole range of things around this. And where was I going with that? Can't remember what I was going to say about that, but it's the rate of loading you've got to restore. And so you start with very slow rates of loading, no rate of loading, you then increase the rate of loading. That's one thing. If you are increasing the rate of loading on a tendon, you can't add external weight. You have to go with body weight loads, because if you increase the rate of loading, that's a massive increase in tendon load. And if you add external weight, you blow that tendon out of the water. You can add external weight to somebody with a history of tendinopathy. I think you need about 12 to 18 months rehab, or back at training and playing before it will take what I would call plyometric. So plyometric for me is a combination of speed, load, height. We stick with speed in tendons. We just do rate of loading increases. We stay away from external loads. They're a disaster. And we stay away, I tend to stay away from anything except self-generated height. Very happy for people to jump, but I'm not that keen on adding height that they haven't necessarily produced themselves. So I'm not a big box jumper or drop jumper or any of those things, unless there was a very good reason for me to think that that person needed that in their sport. So if there was the world, box drop jump thing championship, then sure, drop them off a box. I don't care.
Right.
But that's not what most people need. They need to be able to, and the highest patellar tendon load is jumping. It's not landing. Landing's a relatively low load for a tendon. It's the takeoff that's the key thing, because that's the maximum length of the tendon, the maximum energy storage. If you think about a spring and it's here, and if you're going to stretch that spring, that's right at takeoff there, or push off in an Achilles, that's the point of rupture. That's the point where the spring gives way. Okay, it's not as you come back in here. It's right at that point where you're just about to turn it around and give that energy back to the limb. So rate of loading, so critical.
Yeah. No, that, like I said, I think that sometimes load gets confused, and when we're talking tendon load, we're talking rate.
Yep.
Plus, obviously, there's force that has to be. Okay. No, that, I think that was very helpful for that. What I'm going to do is move on. If you've got a couple more minutes.
Yeah, of course. I'm going nowhere at the moment.
Okay.
I was, but I'm not anymore.
Okay. Well, we got a few more questions here. We did touch on, Jill asked about loading at various joint angles. We talked about that a little bit for muscle, but what about tendon? Do you think it matters to load the tendon at other joint angles?
Yeah, there's pretty clear evidence. The longer the musculotendinous length, the more load on the tendon. So you do need to be loading towards the outer range of your muscle tendon unit. Plus, that's where you actually get your maximum energy storage at point. You do need to have a longer length, musculotendinous length to be able to do that. So yes, you do need to do that. The problem we run into in tendons is, particularly for Achilles insertion, plantaris, hamstring, glute med, is longer muscle tendon length induces a compressive load on tendons. And that's our second load that creates problems for us. So as soon as we get to that outer range, we get compression between the bone, the tendon insertion into the bone, and the actual bone itself. So we have to be constantly manipulating as we get to our higher tendon loads. We're thinking about the range that it needs to work in. We're thinking about the rate of loading. We realize that the rate of loading is increasing the load on the tendon massively, but then we've got this compression issue as well towards the longer lengths. So it's a constant sort of juggling act, and it's always predicated on what the person needs. So if they don't need big compression loads, don't go there. If they don't need, well, they always need rate of loading, because that's what gets them in trouble in the first place. Right. So you're always thinking about what they need and what loads you need to be applying to it. But it can get quite complex towards the end, where you increase the rate of loading, they're gobbling it up, and everything's going really well, and then you add one exercise that adds a little bit of compression, and kaboom goes the tendon. You've got to come back and keep away from that compression, and it's never linear.
Which is also going back to something you said earlier about adding one thing at a time. This is conversation day one with my patients is, I'm going to add one thing at a time, because if I mess up, I want to know that I messed up.
Yep.
If I add 4 things, I don't know what happened.
Yep.
So to clarify, if I'm understanding based off of what you said, and also just my understanding of this, for the tendon, you don't need to load in multiple joint angles. You just want to make sure that if you're doing tendon isometrics, you're loading into a longer musculotendinous length. You don't need to then also do shorter angles as well, right?
No, No.
Yeah.
So the best we know from Ebbs's work is we chose 60 degrees of of knee flexion because that was the point of maximum load. You know, no point putting your isometrics in a range where you're not going to be effective. And what we know about in the Achilles is, you know, say it's a plantaris or an Achilles insertion, we always load higher in range because lower in range creates our compressive loads. But our isometrics seem to be less effective in those. And I think it's because we're not loading them at a longer length. So we're not getting as much load through the tendons. So we tend to aim for just above plantar grade for our Achilles in terms of our isometrics. But, you know, again, at point A where you're starting your isometrics, you're thinking about, does this person need massive ranges of dorsiflexion load? If the answer is yes, have a go at loading them in dorsiflexion, even in your isometric phase. So all of these decisions are constantly going through your head, thinking, you know, will I start them there and will I add, you know, when will I put them into, you know, all of those things have to be thought through.
Yeah. So basically, life is always asking you questions the same way I do, right? Multiple.
Yeah.
Yeah. The sort of that actually takes us. The other one asked, do you have a specific benchmark for when you go from your isometrics to your heavy slow load?
As soon as possible.
Yeah.
We will almost never use isometrics in isolation, except in somebody who comes in completely disabled by their tendon pain. We'll start them with isometrics. And a classic example of that is our glute med ladies. So these ladies are, you know, just devastated by their pain. You know, can't sleep, can't walk, can't get up and down the stairs. They do exceptionally well with just isometrics, particularly in the early phase. Plus, they've always got loss through the kinetic chain. They've always got rubbish calves and rubbish quads. So you can actually start them on those at the same time as you're doing isometrics.
Sean.
If somebody came in...
Yes, Shefali, if I'm pronouncing that correctly, can you mute? I think we're
so
good. You're good.
If somebody came in with an Achilles and, you know, they were having pain, you know, towards the end of their run, we'd give them isometrics to do before they went running, but we'd very quickly straight into some heavy slow resistance training because we just don't want to waste time.
Yeah. No, it makes sense. I mean, we're, like you said earlier, we're still training the muscle, and isometrics you can specifically train the muscle with isometrics. It just has to be intentional, and it's not the same approach that you described earlier. It's different if we're trying to hit muscle than the tendon. This question is, I'll preface it by saying you wrote a whole paper on this, so, you know, read the paper, and then, but for you, Jill, anything beyond what your thing on why is tendon pain often a linear dose response to load versus other conditions having alternative pain patterns? So instead of re-exploring the things you've written on it, is there any sort of current opinion on that, or what your thoughts are?
That's a pretty tough question. So
and we're fine because this could take a long process to get there. So if you just want to say, hey, I've written about this, that's fine.
I think the answer is we don't know the source of pain in tendons. What we do know is it's load dependent, and it's way more load dependent than a lot of musculoskeletal conditions. And so it tends to be responsive to load in a very clean fashion. I mean, you know, if you're stupid, go into tendons because it's not that hard. You know, you try and deal with somebody with patellofemoral pain and it hurts a bit here and it hurts a bit there, and you know, it's very hard to pin down. Tendons are so easy. Load it, it hurts. Unload it, it doesn't hurt. And so I think that really clean relationship with load and pain makes it really easy. And I think that determines the fact that there's quite this linear response. That would be my answer.
Yeah. Plus, like, I mean, ultimately the answer to all of these things is, well, we're not quite sure, right?
Yes. I've always said don't know is a good response.
Right. I have one last question for you, and then we'll wrap this up. I want to be respectful of your time, but anything like currently that's interesting to you Like, what is it that you're kind of excited about from a tendon perspective?
Well, here we go. How can I say? So we did a study a couple of years ago in young dancing athletes, and what we showed was the patellar tendon's very vulnerable to pathology in the pubertal stages. We've got a second study. So instead of having 50 dancers, we've now got 200 athletes. Now that data has finished collecting, mainly because of COVID-19. But I'm very excited that it might show that the patellar tendon is quite different from other tendons in that it's not a load accumulation disease. It's a disease of too much load in a critical stage of puberty. Now, if that's true, and we can biologically age our kids and monitor their loads, we might be able to actually prevent that condition. Now, that's not going to be in my research career. It could possibly be in one of your research career. But just imagine that if we could say, okay, you're biologically at a critical point, we're just going to change your loading for a little while, allow that tendon to mature. Okay, we now have a really healthy tendon, go on and do whatever you like during life. That's fabulous. That would be, just imagine if we didn't have any patellar tendinopathy. Not that we see that much, obviously. So that's really exciting. And the second thing is we've submitted a paper on the role of female hormones, sex hormones in older women with tendinopathy. And I can't tell you the results because it's not been accepted for publication yet, but I can tell you that we've found some positive things. So that gives us an option for these older ladies. It might give us an option. Reading this, please don't go and share this on Twitter or any other social media. Might give us an option for helping some of these older ladies with their horrible glute med tendons and often their horrible Achilles tendons as well, in moving them through this pain situation. So they're the two things that I'm really excited about. Of course, pain, how many things can you be excited about at once? There's a few other things.
Right. No, I think that the developmental window is fascinating because we see similar with, I think, bone, a lot of the research is kind of, and I don't know if this is true or not, but it's starting to seem to me like the stiffer the tissue is, the more those time zones matter. Like probably bone, cartilage, tendon, whereas muscle, maybe not quite as much. And you get longer windows, the more adapt or biologically active the tissue is. We know with bone, there's a sort of sealing effect. It gets stimulated rapidly, right? And then it sort of sits there, but then it also becomes bioactive again relatively rapidly. So you can load it a couple times.
Hours,
Do you find and despite certain claims, we don't know?
I would argue that it's a high collagen based tissue like bone. There's so many parallels in tendon and bone. So we don't actually accumulate much bone after the age of 20. So once you're through puberty, you don't accumulate much bone. That's evident in tendons as well. The tendon tissue you have at the age of 20 is the tendon tissue you have at the age of 80. So I think the parallels are there. So this mechanical deafness, so bone gets mechanically deaf after about 20 repetitions and then won't recover its sensitivity to load until probably 4, 5, 6 hours later. So, you've got to do 20 repetitions and then wait a day and do 20 repetitions, that sort of stuff. I suspect it's the same in tendon, but we don't know.
Yeah, that's the interesting thing, is because then you're juggling global fatigue versus local fatigue. And when it comes to prescription, it really starts getting, if this tendon deafness is a thing and you're prescribing your exercise after you played a game, you might just be yelling on deaf ears. It's fascinating.
If we go back and say that tendon mechanical stiffness only occurs with isometrics or heavy slow resistance and not plyometrics, then if we do our strength training twice a week, we're only actually changing our tendon, stimulating our tendon twice a week. If we jump and run and change direction, that's not going to be doing it for us.
Right.
Whereas it may be for bone. So many unanswered questions.
Yeah, which is what makes it still interesting. Well, Jill, I can't thank you enough for jumping on. It was a pleasure from our end, and hopefully this is helpful for everybody. I know, even if nothing else, getting that sort of definition of tendon load sussed out is, I think, very, very helpful for probably everybody on here. So anything exciting that you want to share? Anything else? If not, we'll finish it up.
No, nothing else exciting.
Well, enjoy. Thank you, everybody, for jumping on. This recording should be available at some point in the future. We'll put it up on our private SIG only sort of site as a resource. Jill, again, thanks so much. Always been a pleasure. And look forward
everyone.
to yelling
Thanks,
about
Jill.
tendons later on as well.
See you later, guys.
Thanks, Jill. You were awesome.
Thank you,
Bye.
Doc. We appreciate it.
Pleasure. Bye.